Hi team, Charmaine here. Today we're going to be talking about parenteral routes of administration, specifically the routes of intramuscular and subcutaneous injections. Parenteral administration of medications is the administration of medications by a route that bypasses the gastrointestinal tract, for example, those injectable routes. The term parenteral administration is often used to refer to injections. So it's an invasive procedure that has to be performed using aseptic technique, something that was introduced to you in Nurse 5081 and Nurse 5082 when we were talking about doing an aseptic non-touch technique for simple wound dressings. We're still using those principles of asepsis and, where possible, aseptic non-touch technique. So parenteral administration, again, we're talking about injections, and that specifically looks at today the subcutaneous route and the intramuscular route. When we're talking about intravenous administration of medications, that's going to usually be delivered it might be delivered as an injection that's placed into the giving set, which was introduced to you last week. So there's an IV fluid line, and then we would connect a syringe that has the medication already in there and connect that to the line and inject it there, rather than directly injecting an IV medication into the vein. But for the presentation today, because of what we're looking at this week, since the patient case study in the labs is really looking at delivery of an intramuscular medication and a subcutaneous medication, we're specifically looking at those two parenteral routes of administration today. So subcutaneous can be abbreviated to subcut, and intramuscular can be abbreviated to IM. And of course, subcutaneous referring to injection into the tissues just below the dermis of the skin, or we could just easily term it as, that fatty tissue layer, and intramuscular, we're going into a muscle. So we're going to firstly start off with looking at subcutaneous injections, and then we're going to look at intramuscular injections. There are a couple of things or principles that are going to apply to both injections. For example, the equipment that we use, and they differentiate slightly, but I'm going to start with the broader concept of syringes and needles. So on the slide here, I've got an image of the actual syringe part. So we're not yet looking at the needle, which is the sharp, we're looking at just the plastic syringe. And we know that, or you might have seen in the labs and on placement, that syringes come in various sizes. Likewise with the needle and the sharps, they come in various sizes depending on what you want to do. For syringes, the plastic syringes that we can see on the screen, they come in various sizes in order to deliver a certain volume of medication. So the plastic syringe consists of a cylindrical barrel, which you can see on the slide, and a close-fitting plunger with a tip that's designed to fit the hub of a needle. And we're going to talk a little bit more about that hub and how it attaches to a needle as well. So there's a barrel, there's a plunger that you can control the drawback and the pushing of the medication. In general, syringes are classified as being either Luer lock or Luer slip. So you see there on the screen it says Luer lock or non-Luer lock. It's either Luer lock or Luer slip, based on the design of that tip of the syringe that's going to connect to the needle. I'm going to show you a couple of pictures that better show you how these differ. But basically the difference is a locking mechanism with the Luer lock type of syringe, and a Luer slip is where it's just push and pull. I'm going to show you some images that will help get a better understanding of this. And of course, these presentations are always to just prepare you for your simulation laboratory lessons. So actually doing it is going to make a lot more sense after you've watched this presentation after you've watched the procedural videos, and then you get to do it yourself, it will come full circle. And of course, doing the practice regularly will help as well. So before I move on to lower slip and lower lock differences, we're using these syringes to draw up a medication and then to deliver the medication. So a syringe is filled by aspirating, drawing back on the plunger, pulling the plunger outwards while the needle tip still remains in the actual solution. So it might be that you're drawing up a diluent, which is what you're diluting your medication with, or you're drawing back the actual medication, and then you're going to use the same syringe, but maybe a different needle in order to deliver the medication. So I'll give you some examples. The most common injection that you would have seen on placement is a subcutaneous injection known as heparin, or another type of subcutaneous injection known as clexane. Now, those ones differ slightly in the way that they're prepared. Clexane subcutaneous injections come in pre-filled syringes. So you only have to, check the medication, of course. We're doing 3 checks of the 5 rights always. But the medications does not need to be drawn up in that syringe because everything is already contained within it. So it's a medication of clexane in a syringe that already has a needle attached, and the dosage is already drawn up in that syringe. Heparin is the one that you would have seen where the nurse cracks open a glass vial, gets a needle that is already attached to a syringe, draws up the medication, places a cap back on that needle in a safe way, and then that needle is the same needle that was drawn up, that was used to draw up the medication, is used to then deliver the medication to the patient. In most cases, we have separate units of syringes and needles. So a couple of these slides, the following slides, are going to show you the difference between lower lock and lower slip. So remember how I said with the parts of the syringe, this is going to just show you the barrel. It doesn't have the plunger, it doesn't have the increment markings of measurement, but it's going to really just depict for you the difference between this hub of the syringe. So this is going to show you lower slip. It's got a male connector in order to connect to the female part of the needle. And so all it is just a push-pull mechanism. You just push gently but firmly. And then with a lower lock syringe, it's got one where you have to sort of screw it in. They have to screw into each other in order to connect. And so the following slides will also show this to you. You have to twist with the lower lock, that's the one on the right. At the very top, you can sort of see this, this spiral where it shows you that you're going to have to turn clockwise or to the right in order to connect the needle to the syringe. And in order to disconnect, you would have to turn left or anti-clockwise. With lower slip, there is no screw mechanism there. It's just push gently to connect a needle to this syringe and pull off gently to disconnect. So it's just really important to know that there are differences that exist and how these mechanisms work. So really what we have in the labs for safety reasons, so that you don't have needles just sort of, popping off because there was no screw lock mechanism. They still have, lower slip still has their place in clinical use, but for injections where we have separated units of a needle and a syringe, we like to use the lower lock mechanism. And so that's what you'll mostly see and here at uni. Another image to depict the difference between lower lock and lower slip. So lower lock, you should be able to see that spiral mechanism again. So we're going to be, as I said, clockwise to the right, makes it tight, This is what I tell my 6-year-old daughter, and then anti-clockwise to the left makes it loose. So just placing it on, placing it off, lower slip gently off, pushing to connect a needle, and pulling to take it off. Another image to depict the same thing. It's very difficult to talk about this with no images, and so hopefully this helps you understand this a little bit more, and again, go so that you can go on into your lab session and feel prepared to do this for yourself. So this just shows you, again, this locking collar or locking mechanism for the lower lock attachment. This, the person who took this photo, I just want to make it clear that you do not hold the needles with your bare hands. Obviously, aseptic technique, you're ruining the you're ruining the sterility of the equipment, but also it's just dangerous. Don't hold an exposed sharp in your hands like that. It should be capped. It should still have the cap or the lid on top of that to protect you and to maintain asepsis of the syringe for the patient. It's just to depict that we're turning we're turning in order to lock the needle into place and anti-clockwise to remove. This likewise shows the difference with lower slip. So there's no collar, there's no locking mechanism. It's just push on and pull off. Again, we do not hold exposed sharps with our fingers. That needle should be capped. So now let's move on to needles. So needles come individually packaged to allow flexibility in choosing the right needle for a patient. Some needles are pre-attached to a standard size syringe. So thinking about those examples I gave at the beginning, where the most common ones you would have seen where they're already attached are the pre-filled syringes of Clexane, or when the nurse is drawing up the heparin for injection. And that's usually, the 8 o'clock injection that's given to a lot of patients. So there was already a syringe, already a short needle attached. They're using it, that contain unit, to draw up heparin. They recap safely, and then, or there's a mechanism that covers the sharp, and they just move that with their finger. Depends on the manufacturer and who supplies that particular hospital. But they use the same needle and syringe that they use for drawing up to then inject the medication for the patient. So, but most needles are, I've never seen a needle that isn't disposable, but most needles are disposable and have 3 parts. So you have the hub at the end, which as we saw in the previous slides, fits onto the tip of a syringe, either through a luer lock or luer slip mechanism. So that was the hub. The shaft, which is connected to the hub, and it's the metal long part. And then the bevel is the very end of a needle. It is the sharp slanted tip which then pierces the skin. That way, when it's inserted into the tissue, the bevel creates a narrow incision that quickly closes once the needle is removed, and that way it prevents leakage of the medication. Here's an image that will show you the variety in sizes and lengths of needles. So you have needles that vary in diameter, and that's referred to as the gauge. And you have needles that vary also in length, and that's always indicated on the package. So it will tell you the gauge, so the diameter, but it'll also tell you the length in millimeters. So from top to bottom here we have a 19 gauge, which is quite wide in diameter. So we usually use an 18 or a 19 gauge needle to draw up medications into a syringe, but we don't like to use them in order to inject into tissues because it's too big and it would be painful for patients. So we try to use the smallest gauge appropriate for the type of tissue that we're going into, and we try to use the shortest length that again is most appropriate in order to inject into the type of tissue. So with subcutaneous needles that we attach onto a syringe of an appropriate size, that needle should be either a 25 or 26 gauge needle, so it's very thin in diameter, and that length really depends on the angle of insertion and the patient that we have. But a 25 gauge 26 millimeter needle inserted at a 45-degree angle for subcutaneous injections is appropriate, or it might be a 13 millimeter needle that's inserted at a 90-degree angle, and that will also, for most patients, get the injection into the subcutaneous tissue. And so you can see if we have 19 gauge at the top, we have that is 38 millimeters in length. Then we have 20 gauge needle, about 25 millimeters in length. 21 gauge needle, 25 millimeters in length. 23 gauge needle, 25 millimeters in length, and a 25 gauge needle, 16 millimeters in length. So the lower the number in terms of gauge is always a wider diameter. The higher the number in gauge refers to a smaller or narrower diameter. So we're using a 25 gauge needle for a subcutaneous injection. We're using a 19 gauge needle for drawing up. This one should be a blunt needle, so there should be no beveled end. This one, if you can see, with the PowerPoint presentation that I upload onto Canvas, if you zoom in, you can see that this has a slanted edge, and that's the beveled end, remember? And for intramuscular injections, we're using anywhere between a 21 to 24 gauge needle. Most commonly what we'll use in the labs and in clinical practice is a 23 gauge needle. And just as a recap, what you have on the screen is a 19 gauge, a 20 gauge, a 21 gauge, and a 23 gauge and 25. So 23 is what we would use for intramuscular injection. This just shows you some different types of syringes already connected to needles. On the right, we can see this is a 5 ml syringe connected to a needle using a luer lock mechanism. You have a 3 ml syringe connected again as a luer lock mechanism to a needle of, I'm not sure what gauge that is. And here you have a 1 milliliter syringe attached to a needle and a half a ml syringe. Where it says, you might not be able to see it, but where it says units at the bottom, if it's in units, it's usually used for insulin. This shows you the type of syringe and needle that's already pre-connected. So there isn't a luer lock or luer slip mechanism. It's manufactured already as one single unit. There's no disconnecting or connecting of the needle. Just to quickly go back, because these are the 1 milliliter version, 1 ml version of this needle is what is often used to draw up the heparin in the glass vial and then to cap it back on. It's the only situation that I can think of in acute care practice where they do recap syringes. Sometimes there is an attachment to the syringe where once they use this needle to draw up a medication, they push this mechanism that's lying on the outside over to the top, and it covers the top of the sharp. Then when they're just about to inject this into the patient, they'll pull that mechanism back. And so there's no risk to safety in terms of the recapping, because really in most hospitals there's a policy of no recapping or resheathing, which is once there's a sharp exposed, we don't put the cap back on because there's a risk that you'll actually end up inadvertently piercing yourself instead of that needle going into the cap or the lid. There are some institutions where they don't have that mechanism, And so what they'll do, and you'll see this in the procedural video, is they'll place the cap with the open end at the top, and then just balancing with the open end at the top, and then they'll place the syringe in there. So there's no way, because you're not holding the cap, you're not doing this in order to recap, there's no way that you can actually create or have a sharp injury. It'll make more sense once you watch the video. So aside from syringes and needles, the equipment that we'll need is what is actually holding the medication that we need to draw up and then administer to the patient. And so you can see on the screen there are two really different types of ampules. You have your plastic ampules on the left, and you'll remember this from these ampules from 5082. When you did your CPA on a simple wound dressing, you had to open a plastic ampule that contained 0.9% sodium chloride, 30 milliliters. And so that was just a twist mechanism where you twist and pull off that lid. But we also have medications that need to be drawn up using a drawing up needle into a syringe. We also have glass vials, which I described to you earlier as the most common example being subcutaneous heparin, and that's really used in acute care, all at the same time every morning. These ones have that thin glass neck that sometimes when you haven't opened them, what you'll need to do is just hold at the top, swirl it around so that the medication that's sitting in the top will just go back into the main part, and that way you won't lose any medication, because you crack open the top and you place your drawing up needle inside and then draw back. So you can see that it has an indicator on the side, and that's to show you where you should be placing your fingers. It really depends who you speak to, but according to the manufacturer, it's meant to be an indicator of where you place your thumb in order to break the glass. Some people think it's where it's what you should indicate as the dot is facing away from you, or it's to indicate where the glass is most breakable. But according to the manufacturer, it's so that you know where to place your fingers in order to snap it off. Now, I've only cut myself once cracking open a glass vial of heparin. It doesn't happen often, but for safety reasons, you might have seen some nurses have a glass vial opener that's just something that sits over the top, and then they'll snap the neck. But what I usually just use, and you'll see this in the procedural video, is the alcohol swab packet, because I haven't used that on the patient yet. I wrap that around the neck and I use it to then crack the vial open. So these ampules contain single doses of medications in a liquid. They vary in size. And we need to aspirate the medication using that drawing up needle, so an 18 or a 19 gauge needle with no beveled end, and that's usually discarded and replaced with the needle that you're going to then use to inject into the patient, which should have a beveled end. This only varies in the case of already pre-filled syringes, such as the example I gave before was Clexane, which is a pre-filled syringe, and heparin, which is drawn up and administered using the same single unit of a syringe and a needle that's already been attached. This just shows you the different steps involved in cracking the glass vial open. So you have a colored ring sometimes, but there's always an indicator dot, and then the breaking level is underneath that. You can use the dot as a way, if you see in step 2, to show you where to hold the glass vial. You then place your other thumb of your dominant hand to crack open the top of the glass vial, and then the top of the glass vial is what you place into a kidney dish. And then after you've finished injecting into the patient, whether it's a subcutaneous or intramuscular, because once you finish injecting, then you have an exposed sharp, you place that exposed sharp straight into the same kidney dish that you've placed the cracked vial, and everything in that kidney dish is considered a sharp. We don't want to fish around and have other bits of rubbish in there. It's a safety risk. You don't want to have a sharps injury. So you just take that kidney dish with your glass vial that's broken and your exposed sharp that you've already just injected into the patient, and you tip it into a sharps bin, the yellow clinical waste sharps bin. So some safety notes about injections. The inability to administer injections correctly can have negative consequences. Failure to select an injection site in relation to anatomical landmarks can result in nerve damage, bone damage. It can also result in failure to administer the medication into the correct tissue. For example, if you inject a medication and it goes intramuscularly, but it was intended for subcutaneous route, or you inject a medication intramuscularly and it was inadvertently injected into an intravenous route. So there are some incredibly important aspects to take note when it comes to injections. It's a lot of responsibility, and we need to make sure that we use the correct anatomical landmarks to find our injection sites. Inability to maintain the stability of the needle and the syringe unit while you're injecting can result, of course, in pain and discomfort for the patient, and it can possibly result in tissue damage as well. When we're talking about intramuscular injections a little bit later, I'll talk about a way that we can make sure that we are in the muscle and not into a vein or a blood vessel. And we also have to keep in mind that injecting too large a volume of medication into a particular site that's not intended to take that volume of medication can result in a lot of pain for patients. So we need to look at anatomical landmarks. We need to look at volumes of the medications and really be able to choose the most appropriate site. When we're thinking about minimizing discomfort, and I think back to when I was a nursing student, 15 years ago, the thing that would cause me the most discomfort was thinking about stabbing people with a needle. It was just something that I felt very nervous about. It was one thing to do it on mannequins, but then to perform this on patients. I remember my first injection, the nurse was, the patient was so nice about it. I think she was a little too nice about it, but she said, "Oh, I didn't feel a thing." And that was very, very sweet of her, because I was quite nervous about it. And I have a fear of sharps usually. I don't like blades and knives and those kind of things. So it was kind of thing that I had to get used to and overcome. And we all have at least one thing that we have to overcome when it comes to the what we do as nurses, whether it's the sight of blood, sounds, particular sounds, or maybe people vomiting and that kind of thing. Mine was sharps. It still is kind of. But we need to think about ways to minimize discomfort for the patient, because that is also some of the fear associated and apprehension associated with giving people injections. I don't want to cause them pain, that's usually part of the reason why we go into nursing, is because we want to help people. We don't want to cause them undue pain. So that's some of the things that we can do in order to minimize discomfort for a patient is to, if the situation calls for it, we can use topical anesthetic creams to reduce the sensation of the injection. We use a sharp beveled needle in the smallest suitable length and gauge for the site that we're going into. We want to position the patient as comfortably as possible to reduce muscular tension. So if we're injecting into a large muscle in the quads, in the leg, then maybe we just want to ask the patient to flex their knee so they don't feel as tense knowing that they're about to have an injection. Select obviously the proper injection site, use the anatomical landmarks, make sure that we're not injecting, as I said before, larger volumes than what that site can hold comfortably. We want to insert the needle quickly and smoothly. You might have heard on clinical placement, if you were on a morning shift and a patient was having subcutaneous clexane, those clexane needles can be not as sharp and as beveled as other needles. And so if you really take your time and inject slowly, then the skin kind of goes down, and then you pierce it. It's uncomfortable for patients. Quickly and smoothly to minimize that tissue pulling. We want to also hold the syringe steady while the needle remains in the tissue. Don't sort of swing it around and move it. The needle's already in the tissue. And we want to inject the medication slowly and steadily and then remove. So inserting quickly, but injecting slowly and steadily and then quickly remove. We want to prevent infection during an injection, and to prevent needle contamination, we want to avoid letting the needle touch any contaminated surface. For example, the outer edge of the ampoule or vial, the outer surface of a needle cap, the nurse's hands, a countertop, the top of a trolley or a table surface. To prevent syringe contamination, we keep the tip of the syringe covered with a cap or a needle when we're not otherwise, drawing up the medication or injecting it into the patient. To prepare the skin, we can just use an antiseptic swab, so an alco wipe. But just keeping the skin clean it will also suffice in a lot of cases. It will just depend on your hospital policy in terms of whether you clean the skin before injection or not. Needle recapping is, as I said, and I'll just touch on this again quickly, the practice of recapping contaminated needles is not recommended, and it is against institutional policy. And we're talking about recapping contaminated needles. So once it's already in the patient and then it comes out, if you think, oh, I'm just going to put the lid back on, you might end up injecting and piercing your own skin after it's already been into a patient's tissue. Do not recap needles that are contaminated. And the only situation where we recap a sharp needle that is when it hasn't been in a patient, and in particular the situations where we are drawing up the medication from a vial and then it needs to be recapped, we keep our hands away. So I'll show you that in the video, but you'll see that I place the lid of the needle or the cap of the needle onto a flat, steady surface, and I keep my hand away, and then I just place the needle back into the lid. So there is no way that I can give myself a sharps injury, even if it hasn't been in a patient. You don't want to have a sharps injury, regardless. So drawing up needles, these ones can be recapped and resheathed because they do not have a beveled end. And so if it's a true drawing up needle, it should not have a beveled end. These cannot, and I have to write it at the bottom in really clear red writing, that they cannot be used to inject the medication into the patient. I don't want any misunderstanding around that. And if there is any misunderstandings, this is why we have the presentation first. You watch the demonstration video, and then when you're in class, you still have your tutor who will facilitate your learning. They will introduce the scenario, They will clarify any points in the scenario, any questions that you have. You perform the skills that are required for the patient that you're being prepared with, and the tutor is to give you feedback around it. Really, if there is any misunderstanding about safety aspects, clarify it with them. But I really want to make sure that everyone understands that we do not use drawing up needles to inject into a patient, that we don't use it to pierce tissue. We are using it to draw up medications from an ampule that might be plastic or glass. We disconnect that. We place on a needle that is sharp and is suitable for the tissue that we're going to inject into, whether it's a 25 gauge for a subcutaneous or 23 gauge for an intramuscular. That is that can be used to inject into a patient's tissue. But we do not use drawing up needles that don't have any beveled end. These are too large to inject into a patient's tissue. And also, it doesn't have a beveled end. It would just be so incredibly painful. And I'm only saying this because in previous years, especially when you're first learning and you're first practicing, sort of misunderstandings can occur or mistakes can happen. And we have had a student, pierce the mannequin with a drawing up needle with a lot of force, clearly. And I just want to make sure that that doesn't happen, especially for future patients. So this is just to show you what the packet looks like, what the needles will look like. Some are red, some are pink, in terms of the hub and the cap, and the box also clearly says it's a drawing up needle without a bevel. So we've taken some time to get here, but we're going to talk about subcutaneous injections now. So we've talked about the equipment that will apply to both types of injections, subcutaneous and intramuscular, but we'll focus now on subcutaneous injections. So these injections, as I said right at the beginning, they involve placing medications into the loose connective tissue under the dermis. Because the subcutaneous tissue is not as richly supplied with blood, absorption of the medication will be slower than with intramuscular injections, which is likewise slower than if you injected something intravascularly, so IV. The best subcutaneous injection sites are the outer posterior aspect of the upper arms, the abdomen from below the costal margins to the iliac crest, and the anterior aspect of the outer thighs. And so you can see those sites on the image on the slide. The site that is most often used for subcutaneous injections, as you will have seen on your clinical placements, is the abdomen. You have lots of other sites not used as frequently and very rarely, but they are possible sites, and these are the scapular areas of the upper back and the upper ventral and dorsal gluteal areas. Any site that you do choose should be free of skin lesions, bony prominences, and large underlying muscles or nerves. There is something called intra-site rotation, and this is where, patients who have regular subcutaneous injections like insulin, like heparin, or Clexane, you might always be using the abdomen because it's the most common site. But then, you'll start to see that patients get little small bruising marks, and so we want to avoid those sites, but also the way that we do that is we just try to give at least 2.5 centimeters away from the previous injection site. And so that's the intra-site rotation, or rotation of sites within an anatomical region. And that way it'll ensure consistent absorption times. So what I have on the screen is from the Joanna Briggs Institute. They compile a lot of different studies around a particular topic and then give you recommended best practice. So it's like a quick guide into, what's the evidence that's out there about a particular procedure, and that way we know that our practice is evidence-based and up-to-date and is considered best practice. And so this is a 2020 summary on the recommended practice for subcutaneous injections. So this report, if you look into it, is available through the University of Sydney Library website. It recommends to inject into the abdomen and have a 5 centimeter radius around the umbilicus or the belly button. Don't go within 5 centimeters of the umbilicus. They do recommend that you clean the skin with an antiseptic swab, allow the area to dry, and inject the needle at a 45 to 90 degree angle, depending on the needle length and size of the patient, which is what we spoke about before when we spoke about needle length. If you're inserting at a 90 degree angle, they want you to use that 2-finger pinch-up technique to lift the skin away from the underlying muscle tissue. And so you might have seen that on placement. If you observed your nurse giving subcutaneous injections, they would have pinched the skin to have this sort of fatty layer pinched up, and then injected the medication at a particular angle. And this report recommends that if you're going to use a 90 degree angle, still use that pinch up technique in order to lift the skin away from the underlying muscle layer. But they also say that if you're going at a 45 degree angle to the skin, that it doesn't need to be pinched. So just keep in mind needle length, needle size, needle angle, and whether you pinch the fatty tissue layer in order to separate it from the muscle layer. And so this summary is based on a search of the literature that really contains, several studies. It could be, systematic reviews that include 23 randomized controlled trials, and these might contain, 1,000 participants, and they base these recommended practice reports on several different studies that are conducted, and you can look into this a little bit more if it's of interest. But I just wanted to tell you that this is what the most current and up-to-date practice is that is recommended according to the research. And so this image shows you that pinch technique and that the nurse is injecting it. It kind of looks like that they're injecting it at a particular angle. So if you might think that that's been injected at a 45 degree angle, but actually it's what it is to the skin. So the skin is lying at this angle, and you can see that the needle is now perpendicular to that, so it's a 90 degree angle and a pinch up technique. And this also shows the alcohol swab just sort of sitting there on the skin, so it's already been swabbed. This image will show you the angle of needle insertion and compare it to the different types of injections that we've sort of quickly spoken about. So subcutaneous injections going into the fatty tissue layer at a 45 degree angle sort of requires that longer needle length. But if you're going into the subcutaneous tissue at a 90 degree angle, you'll have a shorter needle length. Remember, best practice as recommended by the Joanna Briggs Institute was to use the pinch-up technique with a 90 degree injection, and not if you're using a 45 degree angle. And we're about to head into intramuscular injections, which go at a 90 degree angle and use a longer needle length. So hopefully this helps you to visualize where we're at. So, intramuscular injections. This route provides faster medication absorption than the subcutaneous route because of the greater vascularity of the muscle. Muscle is considered less sensitive to irritating and viscous medications, but there is less of a danger of causing tissue damage when medications enter deep muscles. There is, however, a risk of inadvertently injecting medications directly into blood vessels. The nurse, we want to use longer and heavier gauge needles to pass through that subcutaneous tissue and to be able to penetrate the deep muscle tissue. So think back to that image that was on the previous slide, how we use that longer needle. We use a lower gauge, so maybe a 23 gauge needle that is a wider diameter. So remember, all the way back at the beginning of the presentation, the lower the gauge, the wider the diameter. The higher the gauge, the more narrow the diameter. So subcutaneous using a 25 gauge, intramuscular using a 23 gauge, varying in lengths. Each type of injection requires certain skills to ensure the medication actually reaches its target location. And we're going to go through these anatomical landmarks because they are really so important. So before we head into specific anatomical landmarks for the various intramuscular sites of injection, let's quickly recap so we're all on the same page. Let's think about our pelvic bone. When we have our pelvis, we have our femur, which is here. At the top of the femur, we have something called the greater trochanter, which we can actually palpate on ourselves. And this is a great way, palpating on yourself is a great way of being able to practice before you inject this, before you do these procedures on real patients, because they're anatomical landmarks that you can palpate on yourself. So you should be able to feel your hip, which is your iliac crest, and your pelvis. If you go a little bit further down, there's a gap, which is this part here. And then if you go a little bit further down, you should be able to feel your greater trochanter of your femur. So your hip or your pelvis bone, gap as you go a little bit lower, then you should be able to feel the greater trochanter of your femur. Just go from hip, gap, and a little bit lower for your femur. Let's look at an anterior view of the same thing. So if you feel on the side, on your hip, you'll be able to feel this part, which is your iliac crest. That's what you're feeling for. If you go again a little bit lower, you feel just sort of soft tissue. And if you go a little bit lower, that's when you'll feel your greater trochanter. Go a little bit lower, and then you'll feel your muscle and all the way down to your knee. So this is an anterior view. If you actually go back and feel the side of your hip, you'll also be able to, if you move towards the front, if you move anteriorly, you'll be able to feel your anterior superior iliac spine or your anterior superior iliac crest. And that's what you'll feel anteriorly at the front. But if you follow the bone, it actually goes all the way from the front to the top, which is your iliac crest, and then to the back. You'll be able to feel it form a V towards the back into a V shape, and that's your posterior superior iliac crest or your posterior superior iliac spine. So another image. So on the left is your anterior view. So remember, we've got our hip, which we can palpate. That's our iliac crest. If we move anteriorly, we're going to feel that anterior superior iliac spine. If we move just from our hip down, remember we've got that extra space of just soft tissue, and then we'll be able to feel this part, which is the greater trochanter. If we look at the posterior view, so we can feel our iliac crest, and if we feel towards and palpate towards the back on either side, you'll feel it form into a V shape and go down. And so this is your posterior superior iliac crest. So keep that in mind for your anatomical landmarks. The other anatomical landmark that you'll need to be familiar with and palpate on yourself, I encourage you to, is your Acromion process at the top. So this slide will show you your sternum, so we're thinking our rib cage, we're thinking our clavicle, so up here, and if you keep going all the way across, you'll be able to feel your Acromion process, which is on the side. Underneath that, you'll feel a little bit of a soft tissue gap, and underneath that is obviously your humerus. So clavicle, Acromion process, all the way out to the side. Gap, and then your humerus, which is just sitting there underneath. Keep these things in mind as we go into our site choice. So our sites of muscles that we can pick are the Vastus Lateralis, the Ventro Gluteal, the deltoid, and really only in mental health sites is when we use the Dorso Gluteal site. And so we do need to know about it so that you can perform that procedure correctly when you're on your mental health placement at the end of the semester. But the most common ones that you'll see being used are the top three. When selecting your site, consider whether the area is free from infection or any other types of bruisings or abrasions, injuries, or tenderness from injuries. We want to think about the location of underlying bones, which is why we spoke about anatomical landmarks. We also want to think about the nerves and major blood vessels that might be in the area and the volume of the medication to be administered. So at the end, I'm going to show you a summary table of the site, the volume of medication that you can place into that site, and the anatomical landmarks that you need to keep in mind for each of them. Your Vastus Lateralis, it is a good choice. I'm going to show you an image on the next slide, but the reason why a lot of intramuscular medications are injected into that site is because it lacks the presence of major nerves and blood vessels. The Ventro Gluteal Site, so I'll just quickly show you this Ventro Gluteal Site. This is considered a good site. It's a deep site. It's situated again from any major nerves and blood vessels, and you can sort of easily identify it because of the prominent bony anatomical landmarks. Your deltoid muscle, which is just on your arm, it's easily accessible because it's just roll up your sleeve. But it's not a well-developed muscle. We can't use large volumes in there, but we can use it for small volumes of medication. The Dorsogluteal Site, as I said, it's only used in mental health settings, and it can take volumes of up to 4 milliliters. But it's rarely used because of the risk of striking major blood vessels, because you've got that underlying sciatic nerve, and so there is a risk of causing permanent or partial paralysis of the leg that's involved. So it's not recommended in regular practice, but in certain situations, such as in mental health settings, it is. So let's have more of a visual look at each of these sites, knowing their sort of pros and cons. Here we've got the Ventro Gluteal Site, and the way that we can know that we're in the right place. So the ventrogluteal muscle is considered a safe site for all patients, a maximum dose of 4 milliliters. The gluteus medius muscle and the minimus are those deep muscles, and they are away from major nerves and blood vessels. So we locate the muscle by placing the heel, which is this part of your hand. We locate the muscle by placing the heel of the hand over the greater trochanter. So think back to where that anatomical landmark was. We place the heel of the hand over the greater trochanter of the patient's hip, and the wrist needs to be perpendicular to the femur. The right hand is used for the left hip, and the left hand is used for the right hip. We point the thumb towards the patient's groin and the fingers towards the patient's head. Point the index finger to the anterior or anterior-superior iliac spine, which is one of those other anatomical landmarks that we spoke about, and we extend the middle finger back along the iliac crest towards the buttocks. So you can see here with the image, we've got the patient's right hip, the nurse's left hand, the heel of the hand on the greater trochanter, the thumb pointing towards the patient's groin, the index finger palpating the anterior superior iliac spine, the fingers pointing towards the head. And we've got the index finger and the middle finger, forming this triangle of space. And that is the area of injection site. For this patient, for patients who are going to have a ventrogluteal injection, the patients can lie on their side or on their back. So you can see the image below. This patient's lying on their side index finger palpating the anterior superior iliac spine, fingers pointing towards the patient's head, heel of the hand on the greater trochanter, thumb pointing towards the groin. Triangle space for injection site. It's probably more effective to palpate the sites if the patient's lying on their side as opposed to on their back, but it's possible either way, in either position. Still ask the patient to flex their knees though. So here we've got our site for an image for the site Vastus Lateralis. This muscle is normally used in adult clients, and it's for volumes up to 5 milliliters. So because it's such a well-developed muscle, this is really the muscle that we most use in hospitals in acute care. This muscle extends from a hand width above the knee. So just in the procedural video that you'll need to watch after this, just put one hand width above the knee and one hand width below the greater trochanter, which is here, and then we want to go in the middle third section of that muscle. So the patient can still lie on their back, so they can be prone. They can be lying on their side, but either way, get the patient to slightly flex their knee. They can even really be sitting for this injection as well. But when I give IM injections at work, I'll usually use the Vastus Lateralis site, and the patients are lying, semi-fowlers in the bed. So the deltoid muscle. It's easily accessible. It's not often, as I said before, well developed, and so we don't use it for volumes of over 2 milliliters. So that's why often in acute care we use the Vastus Lateralis muscle, but you can use the deltoid muscle. Remember those anatomical landmarks? We want that Acromion process after we palpate the clavicle, the Acromion process. We use this process as our anatomical landmark because then we want to go 2.5 to 5 centimeters below the Acromion process. So looking at the image here, 2.5 or 5 centimeters below the Acromion process, and in an imaginary triangle, that's the site of injection. You can ask the patient to they can sit, stand, or lie down. But they can sort of just flex their arm at their elbow, so it's a little bit more relaxed. We were talking about things that can help decrease or minimize discomfort, and that's a way that we can do that, by asking them to flex that joint and relax that muscle. So let's now talk about the dorsogluteal site for injection. This is the one that is used in most often in mental health and other areas too. And so it's important to talk about the site and the correct anatomical landmarks because, as I said in the beginning, it is associated with that higher risk of paralysis in the affected leg because it's got the sciatic nerve and major blood vessels as well. So again with the imaginary lines, but we use the anatomical landmarks of the greater trochanter and the posterior superior iliac crest or posterior superior iliac spine. And if you draw an imaginary line from the posterior superior iliac spine and the greater trochanter, the injection site is above that line. So it says here superior to the imaginary line. And that way, if you look on the image on the right, we can avoid these major blood vessels and the major nerve, which is your sciatic nerve. So if we can end up being on the outside of that. So now I'm going to talk about an administration technique used for intramuscular injection, and it's called Zed Track Technique. This involves pulling on overlying skin during the injection, and this is going to move the tissues to prevent later tracking. So the image on the top shows the lateral tension that you apply before you inject, and then after you withdraw the medication, withdraw this needle and syringe, then you release that lateral tension, and that way it keeps the medication in that space. So this shows the lateral tension for before and during injection, and then this shows after the release. See that top layer moving to the side, and this is that track of where the injection was, and then it gets sort of locked in because you've placed the tissue back. So that Zed Track technique is recommended to avoid the medication coming back out and leaking out of the intended space. So it's just going to help seal the medication there. So I just refer it to as lateral tension for the Zed Track technique. Going back again to the Joanna Briggs Institute around for best practice around intramuscular injections. Now, this is specifically with regards to aspiration. Aspiration means that sort of drawing back or drawing up. Now, with intramuscular injections, as you'll see in the video, I demonstrate aspiration while I'm in the site of the particular muscle that I'm in order to see if there is any blood that might appear in the syringe, and that would indicate that we are in a blood vessel and not in the muscle. It's considered a controversial procedure, and really what it aims to do is to prevent or to avoid intramuscular injections being inadvertently delivered into a blood vessel. That's what we're looking for. We don't want to see blood in the syringe, and that way we know we're in the right spot. When they've looked at all the literature available around this, the data really suggests that intramuscular injections, when it is performed correctly, doesn't really have a chance of entering major blood vessels due to the physiology. So if you really are in the right spot, you've selected your you've selected your site, you've palpated for the correct anatomical landmarks. They're saying it's not really a risk that you'll be in a blood vessel. They're actually saying that it causes more pain to aspirate, and so you should really kind of think about whether it's worth the extra discomfort to patients. It's based on several and really a number of different research studies out there, and essentially what the conclusion that they've come to with regards to best practice around aspiration is that it's a painful procedure. It's largely unnecessary and therefore should be avoided. And they put a caveat and they say, however, the potential consequences of injection of the medication into a blood vessel, as well as the level of experience that the person who is administering the injection, these factors should be considered in order to make a risk or benefit assessment. And so they also say that some medications intended for intramuscular route actually comes with a recommendation from the manufacturer that aspiration must be performed, and so of course in that situation you must. And so what they're saying is, if it's a particular type of medication that the manufacturer stipulates that you must aspirate to ensure that you are not in a blood vessel, then do it. And if in doubt, you can aspirate, but it causes pain. Again, there's really no hard and fast rule, so I still do it as a precaution. But I don't aspirate and pull back a lot so that it would be more painful. I just aspirate ever so slightly, because if it really was in a blood vessel, you will see that blood draw back into the syringe. Here's the summary table that I talked about at the beginning. And so this is what we're finishing with: the summary of anatomical landmarks for IM injections, deltoid, Ventrogluteal, Vastus Lateralis, the patient position that they should be in order to relax that muscle, the maximum volume that that muscle can take without causing more pain, and the anatomical landmarks that we are looking for. So deltoid, where the patient can sit, stand, or lie, can take anywhere equal to or less than 2 milliliters, and we're feeling for the Acromion process. Ventro Gluteal, the patient can side lie, they can lie flat, but it's easier to palpate the anatomical landmarks if they're lying on their side. It can take up to and including 4 milliliters. Remember, you're using the opposite hand to palpate for the anatomical landmarks of the patient's side. So if you're injecting into the patient's right hip, then use your left hand to palpate for anatomical landmarks and your right hand to inject. We're feeling for the greater trochanter of the femur and the anterior superior iliac crest. Our vastus lateralis in the quad, the patient is lying, they can lie semi-phallus with their knee flexed. It takes anywhere up to and including 5 milliliters, so a really great accessible site for patients in acute care. We're going one hand width below the greater trochanter, one hand width above the knee. The Dorsogluteal site, most often used in mental health settings. The patient is prone. It's taking anywhere up to and including 4 milliliters. And we're feeling for the greater trochanter of the femur and the posterior superior iliac crest. So all of these things you learned, and after this I encourage you to now watch the procedural video on intramuscular injections, and then when you're in class, go through the scenario with your tutor. This year we only have an hour in the labs in order for you to practice and get feedback on your skills. So I wish you all the best of luck. Please clarify any questions that you have with your tutor, or you can email me and contact me, or place any questions on the discussion board as well. And I'll see you later this week.